Okay. Hmm. Okay. ठीक, sound out. Should I start? Good morning, everyone. Today's my topic is about syphilis, that is serological test for the syphilis and testing algorithm. And my moderator is Dr. Seema ma'am. Yeah. Before knowing the syphilis, the father of the modern medicine, that is the William Osler, told that he who knows syphilis knows medicine. Why? Because syphilis is a great imitator of all the diseases. Introduction. Treponema pallidum is a fastidious microaerophilic spirochete that has four subspecies. The subspecies pallidum, subspecies endemicum, subspecies pertinae, and subspecies keratium, which causes venereal syphilis, endemic syphilis, yaws, or pinta, respectively. Treponema pallidum subspecies pallidum is sexually acquired, and Treponema pallidum subspecies differ pathogenically. All these subspecies differ pathogenically, but they are 95% homologous by DNA hybridization and are serologically indistinguishable. Now, the natural history of the syphilis goes like this: after the inoculation after the inoculation in the skin or the mucous membrane, it takes around average of about 3 weeks for the incubation period. Then comes the primary syphilis, which will later go into the secondary, latent, and tertiary syphilis, and the duration will be around like 3 to 10 weeks from primary to secondary. From secondary to latent, it will take around 3 to 12 weeks, and from latent, some 25% of the patient relapses within the 1 to 2 years. Like after the latent syphilis, it around takes 20 years to go into the tertiary syphilis. This is the natural history of the this is natural history of untreated syphilis. If it is treated at any point of time, that may stop. Coming to the clinical manifestations of the syphilis, starting from the primary and secondary, that affects the skin, mucous membrane, regional lymph nodes, and can have been misleadingly benign manifestations. Like example, painless chancre, rash, fever, malaise, muscle aches, and lymphadenopathy. And the rash typically here is maculopapular rash, and the differential diagnosis for the maculopapular rash would be secondary syphilis, chikungunya, hand foot mouth disease, erythema multiforme, and next one. Going to the tertiary syphilis, it can occur in the any it can occur in any organ. Why? Because it distributed through systemically, and the tertiary syphilis is associated with the serious complication like cardiac and neurological complication, and neurosyphilis is a serious complication. Transmission primarily, as we all know, syphilis is STD, that is sexually transmitted disease, and not just sexually transmitted disease, it is also vertical transmission, that is from the mother to the baby in utero, and transmission via blood products and the organ donation. The risk of transmission and impact of the maternal syphilis and pregnancy outcome. As we all know, the increasing importance of the congenital syphilis. So, slide or two about the pregnancy related syphilis. So, according to the CDC 2012 fact sheet, the 69% of the untreated infected pregnant women will experience an adverse pregnancy outcome, and 25% of in utero infection result in late term miscarriage or stillbirth, and 11% culminate in neonatal demise. Infection of the fetus in utero can occur at any stage of the infection in an untreated mother, but is most likely to occur during the early syphilis. The risk of the infection decreases progressively thereafter. and the infection of the fetus occur from about 14 weeks of gestation only, with the risk of the infection increasing with the gestational age. So the reason being the placenta is generally here it says that the syphilis cannot happen before the 14 weeks, only happen after the 14 weeks. The reason being is the placenta will be formed by the 12 weeks, and the fully functional placenta, that is the invasion of the spiral arteries, is will occur by the end of the 14 week, and spirochete will transmitted to the baby through hematogenous route only. So by the 14 weeks only the fetus will be infected from the mother, and thereafter it will as the gestation increases the contact will increase. Coming to the laboratory diagnosis of the syphilis, as we all know, it is divided into serological and the direct demonstration. In the direct demonstration, we have microscopic confirmation, PCR and antigen detection. In serological diagnosis, we have non-treponemal and the treponemal test. And the next slide will be one slide of each of the serological and direct demonstration. Coming to the direct demonstration first, that is the direct demonstration of the Treponema pallidum is animal inoculation, a dark field microscopy, then the direct fluorescent antibody test, direct test for the Treponema pallidum in tissue sections, and nucleic acid amplification test. Since my topic is about the serology, I would not be dealing much of these. Only some part I will be dealing here, like dark field microscopy and direct fluorescent antibody test. So in the direct test, to diagnose and to appropriate the treatment, careful review of sexual history and physical presentation can be used. So history and the physical, that is the chief complaints of the patient. In primary syphilis, with an open chancre, direct visualization from the fresh specimen is used. Then microscopic methods can be used earlier in course of the disease than any other test. Like within 1 week of the infection, these direct tests can be used. So this left, so this right is the right is the diagram regarding the dark field microscopy. So the dark field microscopy, the dark field microscopy, the principle is here there will be an opaque disc which will not allow the which will allow the light from the peripheral directly into the specimen, and then the objective lens, then the only light reflected by the specimen is captured by the objective lens, and thereby enhances the visualization of the organism. The next, the limitations of this direct methods will be, it is labor intensive, must be performed at the point of care, must be examined with the minutes of the collection. Use of specialized and expensive equipment, that is the microscope, and operated by the personnel with the appropriate experience and training. When we are talking about the limitations, one more limitation with regard to the direct, that is the dark field microscopy, is that it cannot differentiate between the pathogenic Treponema pallidum species and non-pathogenic Treponema pallidum. Like when we see the demography of this non-pathogenic Treponema pallidum, all look same. So this cannot differentiate, but this has overcome with the help of direct fluorescent antibody testing. So these are the non-pathogenic strains, that is pallidum refringens, vaginalis, Ritus treponeme, and denticola. And these are not just present in the genital area, but it can also be present in the oral flora, like denticola. Now, coming to the treponemal and non-treponemal test, it would be starting from the non-treponemal test, the VDRL and RPR, which is microscopic and macroscopic respectively, and then USR, that is unheated serum reagent test, and then the toluidine red unheated serum test. Then in the treponemal testing, we have the complement fixation test, that is Reuters protein complement fixation test, then immobilization test like Treponema pallidum immobilization test, then TPP, that is agglutination test like Treponema pallidum particle agglutination, and then immunofluorescence test like FTABS, that is fluorescent treponemal antibody absorbed, then fluorescent treponemal antibody FTA 200, then fluorescent treponemal antibody absorption double staining, and then the heme agglutination test like TPHA and MHA-TP, that is micro heme agglutination, and then Treponema pallidum heme agglutination test. Then enzyme immunoassay comes here is the Trep check and the Trep show, and the chemiluminescence assay, that is CIS, the Diason and the RT. Going to the non-treponemal test first, that is the VDRL and the RPR. They can be performed as quantitative test and the qualitative test. Qualitative test, that is the presence of the absence, that is reactive, non-reactive, and the quantitative test is to check the amount of the antibodies present in the serum. Except for the VDRL and RPR, except for the VDRL and RPR, most other lipid and antigen tests are not used. It is therefore, it is the non-treponemal test. It is used for initial screening and for the follow-up of the treatment, which is the important point here. And coming to the first test, that is the VDRL test. It is a flight flocculation test. It is a flight flocculation test, and the flocculation and precipitation is nothing but the same. But the flocculation means that the precipitate, that is the antigen antibody complex, that is the precipitate product, is forced to remain the suspended, whereas the precipitate will remain at the bottom, that is sedimented. Then the site for it is VDRL antigen. Cardiolipin antigen is alcoholic solution which is composed of both cardiolipin, lecithin, and cholesterol. And the principle is the cardiolipin, which is the non-treponemal antigen, which when treated with the when reacted with the antibody which is present in the serum of the patient, causes the antigen antibody reaction in the slide test. Then coming to the coming to the result, this is the negative result, and that is the positive result with the precipitation. That is flocculation. Coming to the false positive VDRL, we all know that there happens in VDRL the false positive result, that is biological false positive result. What is biological false positive? It is the variation in the normal. In some normal individuals, there may be excess production of the reagent antibody. So that is called biological false positive. That is in normal individual. Then the reasons for biological false positive is infectious and non-infectious. In the infectious, it is the organism calling back to the endocarditis, chancroid, leprosy, and then viral we have HIV, chickenpox, infectious mononucleosis. In parasitic we have malaria, trypanosomiasis, and the most common biological false positive is due to malaria. And in non-infectious causes, advanced cancer, it is chronic liver diseases, connective tissue diseases, and pregnancy. In non-infectious, it is mostly the pregnancy only. Then coming to the next, it is after reading about the false positive, there is something called false negative VDRL also. Why does it occur? The false negative VDRL is due to the phenomenon called Poisson phenomenon. Now, what is Poisson phenomenon? When there is excessive amount of antibody, it is called Poisson phenomena, and that might lead to the false negative VDRL. Why does it antibody excess happen? It's because due to the undiluted specimen having high quantities of the reagent antibody occasionally can give rise to the false negative. Then if there is excess of antigen, it is called Poisson. And it can be false negative can be due to HIV, early or late syphilis. Now, then there is a concept of the there is a concept of the concept of serofast, that is the seroresistant. If there is a first we should know what is how to interpret. If there is a fold-4 rise in the titer, it means that it is an infection, reinfection, or treatment failure. And if there is a fourfold decrease in the titer, it is effective therapy. When non-treponemal test shows persistent reactivity with no signs of decline in the titer after 6 months of adequate therapy, or fail to show fourfold decrease of initial high titer within 1 year, it is called seroresistant or serofast. Then this is about the VDR. Then coming to the RPR test, it is a rapid test and can be obtained within the 10 minutes, and can be used as a rapid point of care test and used for the mass screening. It incorporates the carbon particle which enable test to be performed on the disposable paper card, and it does not require the microscope. Coming to the, this is about the non-treponemal. Then coming to the treponemal test, why it is called treponemal test? Because here the entire treponemal fragment, entire treponemal organism or the fragment of it is used as an antigen. It is used for the confirmation of the disease, and here the important point is it remains positive even after the adequate treatment, which is not true for the non-treponemal test.
Dr. Roslyn has two questions. She wants to go till the end.
The slides are there for it. Sensitivity slides.
Okay, carry on.
The first test is the fluorescent treponemal antibody absorption test. It is an indirect immunofluorescence test where the Treponema pallidum is coated with an antibody which is stained with the conjugate, and the conjugate here is fluorescent conjugate animal anti-human antiglobulin. And then there is a complex which is seen by the tactile microscopy, and then we can visualize the organism. Then next comes the TPHA, that is heme agglutination. Here the RBCs are coated here, the avian, or also we can use the sheep RBC, which are sensitized with the Treponema pallidum antigen. Here the patient serum containing IgM or IgG specific for the Treponema pallidum antigens coating the RBC, that is the Nicole stain, and then these bind and form the agglutination in the micro titration plate. That is about the Then next is the Treponema pallidum TPPA, that is the Treponema pallidum agglutination assay. The type of specific Treponema test for the syphilis. Before we use the to sensitize, that is we have sensitized the RBC with the treponemal antigen, but here we have used gelatin particles are sensitized with Treponema pallidum antigen, and here the particles aggregate to form the clumps when patient serum is positive for the syphilis. Then coming to the rapid point of care test, with the resurgence of the syphilis, it is very hard to reach to the high prevalence individuals like commercial sex workers or MSMs and the pregnant women. So in that scenario, we need something which is very rapid and affordable and cheap. So they have developed a rapid point of care test which should meet an assured criteria which was set by the WHO, that is affordable, sensitive, specific, user-friendly, rapid/robust, equipment-free, and delivered. Then it is a type of agglutination test and immunochromatography. It is a immunochromatography test. Most of the tests which is used in the syphilis is immunochromatographic test. Now this is the which is the meta-analysis which shows the rapid point of care test, which have shown the which have compared 5 different types of rapid point of care test. Then this is the summary of that study, that is POC. These are the rapid point of care, that is Determine, SD Bioline, VCTech and Syphilis, which can use serum or the whole blood, and the sensitivity of the Determine is around 90 from the serum and 86 from the whole blood, and the specificity is around 94 to 95, and Bioline from the serum and the whole blood it is around 87 to 84% to and specificity to 95 to 97. Then VCTech serum and VCTech sensitivity is 85 to 74%, depending on what sample we are using. Either we are using serum or the whole blood, and specificity is around 96 to 99. And then in the Syphilis we have 74% sensitivity and specificity is around 99%. So in this meta-analysis they have compared only these 4 rapid point of care tests. But WHO has verified these following 8 rapid tests, that is elite determined syphilis test, which can and this rapid test can be used from both treponemal point of care test and non-treponemal point of care. Not just that, they have also developed the combined test for the syphilis and HIV. These are the following WHO recommended, that is allele determined, omega visited, Syphilis, bioline, syphilis, and then dual path, that is for dual treponema and non-treponemal POC. Then SD bioline, that is the rapid test, combined syphilis and HIV point of care test. And then we have DPP HIV syphilis assay, that is combined HIV and POC. Then multiple rapid Treponema pallidum HIV antibody testing, that is combined syphilis and HIV POC. Here the antigen they have used are 3PN15, that is these are the membrane proteins which are derived from the Nicole strain, TPN17 and TPN47. These are the rapid point of care tests. Now, to understand or to interpret the interpret the serological test used in the syphilis, we should know the dynamics of the serological response in the syphilis. As we can see here, the non-treponemal antibodies, that is IgM, can rise fast and can clear from the body very fast. That is the IgM. Whereas the non-treponemal test, which can be used by detecting TFBS and TPHA, can remain lifetime or for about 10 years or so. Then coming to the sensitivity and the specificity of each test depending on the stages. Primary. So VDRL in primary stages it is around 78%, and in secondary it is 99 to 100%, and in the latent it is 96. As in from this table, as we can see, in the primary stages the sensitivity is not much, whereas in secondary and in the latent stages the sensitivity is reaching around 99 to 100%. In the late, again it is dropping by from 70 to 99%, whereas the TPHA or the TPPA even in the late stage can detect around the sensitivity is around 99%, so as in case of the primary, the TPHA and TPPA can detect in the early stages, whereas the specificity is around 96% for the TPHA on TPPA. Then coming to the serological, these are the like expanded table. Here the sensitivity and the specificity of the treponemal and the non-treponemal test, and in previous slide I discussed about the percentages. Then ease of use will be non-treponemal tests are very easy to use, or you can say moderately hard, and then in the treponemal tests which are very complex and moderate and not that easy, and POC is definitely then easy. And the lab level where we can use these tests would be non-treponemal tests we can use in the clinics, in the PDs or at the site, whereas the treponemal test can be used only in the reference laboratory or the tertiary setup. Whereas the POC can also be used, since it is easy to use, we can use it in the clinic or on the site. And the advantages is simple, rapid, economical, sensitive identify active infection and monitor response to treatment. And treponemal tests are confirmatory and very specific, whereas the point of care test, where whole blood or no active room temperature we can keep it at the room temperature and whole blood can be used, and immediate treatment we can start, and the result can be obtained, that the visual result can be obtained within the 20 minutes. The disadvantage of the non-treponemal test is it is non-specific. As we have seen, it is biologic. It can have biological false positive, can occur frozen phenomena, cross reactivity, cold storage of the reagents, electricity. These all things are required for the non-treponemal test. But then coming to the disadvantages of the treponemal, it is technically demanding, and it requires the equipment and don't differentiate between the active or past or treated syphilis. And so is the case of the rapid point of care test, where it does not differentiate between active or past infection.
Okay, just hold on now. Regarding these tests, there are a few questions. Then you go on to the algorithms. Dr. Rosalind wants to know what is the sensitivity of DSM.
The dark field microscopy, it is around 50 to 60%, because only the dark field microscopy can pick up the organism only if it is an open chancre or oozing exudates from it, only that can pick up. So sensitivity is not that good, and the limit of detection for this is around 10 to power 5.
She also wants to know the antibody of T pallidum cross-react with other treponemes. That's
Antibody.
her question.
Antibody of the treponemer. No, it.
You have covered it in one of your slides.
It doesn't cross-react with the other Treponema pallidum species. That's why we have used DFA TP. DFA.
We are talking of antibody.
Antibody. Okay.
We are not talking of DFA TP to improve. Think, relax, think. सोच के बताना. Give the answers, okay? Dr. Hitinder wants to know, we can divide the false positive non-treponema tests in acute false positive and chronic false positive.
Yes, sir. We can actually divide this based on the acute and the chronic false positive. But since like this is an infectious, I tried dividing it into the infectious and the non-infectious causes. In acute and chronic, we have in acute we have pregnancy and the SLE and the connective tissue disorders, and in chronic we have HIV and other cancer, chronic liver diseases. These are the chronic liver diseases. So,
Dr. Nishad wants to know, dark field microscopy is used for what samples in different stages?
dark field microscopy, the dark field microscopy is generally recommended for the primary syphilis and the congenital syphilis, and the samples we can use is from the chancre, the oozing liquid, which we can just take it freshly prepared slides and then stain it, and then you can use it in the dark field microscopy. In the congenital syphilis, you can perform it on the amniotic fluid.
Okay. She wants to know in which stage proton phenomena is most commonly seen. Dr. Nishad's question.
Antibodies are excess. I'm not sure, Nishad ma'am. I will look at and see about the proton phenomena common in which stage.
Dr. Minta wants you to expand on POCT, basis being agglutination test. Are there any FDA approved agglutination tests?
No, the rapid POCs which are FDA approved are only based on the immunochromatographic test, but not on the agglutination test. And what all I have shown are all FDA approved, and there are just 8 FDA approved rapid POC which I have shown in my previous slide. These are the 8 FDA approved till now.
Dr. Rathod wants to know what tests are done to evaluate congenital syphilis. You will come to it.
Yes, congenital syphilis.
Okay, Dr. Roslin wants to know what is the major advantage apart from what is listed on VDRL over all the treponema tests.
That is it. It can detect the active infection first, and the second is it can monitor the treatment therapy. This is the major advantage of the VDRL.
Anything else?
It can be performed at basic laboratory and.
Leave it up.
I'll
Dr.
find it.
Nitendra wants to know, can treponema tests, serum agglutination tests give false positive reactions in some conditions?
I don't know. I don't know.
You check up. But you have read it. So check up and reply, okay? Dr. Nishad Hussain has replied, DFF also done on skin and mucosal regions in secondary and congenital. That you have mentioned. Proton phenomena very common in secondary and congenital syphilis. Okay. Now go on. Now with one more. POCT is ELISA based or agglutination based?
It is ELISA.
POCT, what is the format?
ICT based. It is an ICT based immunochromatographic testing where it is coated with the colloidal antigen and then antibodies, and then it is ICT based. It is neither of the two, ELISA or the agglutination.
Okay, go on. Now we'll take the rest of the questions at the end.
Now, come after this, now going to the algorithm which has been used traditionally and in the newer trade is this. Then the algorithm what we use is from the since very long time is the traditional algorithm is the first. As soon as the sample comes for the syphilis, test it with the non-treponemal test, that is example we can say RPR. Here then with the if it is a positive, that is if it is reactive, then go for treponemal test, that is the TPPF. And if it is non-reactive, the interpretation could be like syphilis is unlikely and too early to detect. If the clinical signs point to incubating or is suspected primary syphilis, treat with benzathine penicillin G. If it is and if TPPA is again positive, then evaluate clinically. That is, if there is any past infection and treatment, if there is any current infection risk, and administer the therapy according to the CDC guidelines. Then, if it is if it is negative, then the person might be at risk and repeat the RPR after the several weeks. Then this was the traditional algorithm which was followed since many decades. But with the commercial availability of the automated system, they have now shifted to the reverse algorithm. Now, both the formats were originally manual. This approach made sense from the both workflow and the cost perspective. Then commercial availability, including both EIA and fully automated CIA, has suggested an alternative approach to the syphilis screening. And reversing the order make the testing less labor intensive while retaining the diagnostic accuracy. Thus, many laboratories has reversed the order, leading to the development of the reverse sequence syphilis screening algorithm. Coming to the reverse sequence syphilis algorithm, here they used EIA or CIA, that is immunoassay or chemiluminescence assay, as the first test. Then, if it is positive, then do the quantitative RPR or other non-treponemal test. If it is negative, there is no point. Then just treat the patient and send it. And if it is positive, evaluate if there is any past infection and treatment or any current infection at the risk, or administer therapy according to the CDC guidelines. If it is negative, go for the TPPA because there is a discordance here. Go for the TPPA. If it is positive, again go back to the treatment and assess the and evaluate clinically. If it is negative, repeat the RPR in the several weeks. So this is about the reverse sequence algorithm. Just comparing between the two algorithms, that is the traditional algorithm and reverse sequence algorithm. Here, the traditional algorithm is reliable, especially in high prevalence settings, utilizes rapid, inexpensive screening method, and it is economical and easily implemented in most of the hospitals and the clinic. And in our hospital also, we use the traditional algorithm because of these advantages. But in the reverse sequence algorithm, the objective interpretation of the screening result, and it is an automated testing. So, since it is an automated testing, it has enhanced its sensitivity and the specificity, especially during the late stages like late or the latent syphilis, and detects early primary and treated infection that might be missed during the traditional screening. The disadvantages, it will be low throughput and subjective interpretation of the results of the non-treponemal assay, high rates of the false positives, especially in the low incidence setting, and misidentification of early primary and treated infection. The disadvantages of the reverse sequence syphilis, as it is automated, it is high cost and increased detection of the sample with reactive screening results. That is a discordant sample. Now, what is the verdict? So what do we follow? So both the algorithm, we should know that both the algorithm has the advantages as well as the disadvantage, that is the limitation. Now, implementation of the reverse sequence has provided an opportunity to automate testing, increase throughput, and enhance sensitivity. Now, CDC says that if there is a discordance, that is EIA reactive and RPR non-reactive, the testing has to be the confirmatory test in that case would be TPPA. Now, the clinicians and the microbiologists should be informed and educated on the benefits and interpretative challenges of both the testing algorithms. Now there is now there is one more algorithm which was recommended by the European CDC, that is ECDC algorithm, but which is not used anywhere. but it is used only in the some of the European countries. Like here, they first go for the treponemal testing, that is the EIA. If it is positive, they again go for the second treponemal test, which is a modification of the reverse algorithm only. So in the second treponemal test, if it is positive, then they label it as a syphilis positive. If it is negative, then they label it as a negative. The advantages of this algorithm is it is high accuracy, and yes, it has high sensitivity and specificity in serodiagnosis of different stages and high consistency. The disadvantages but the same like reverse algorithm, it cannot differentiate between active and old disease, that is treated and untreated disease, and it can lead to false positive result with EIA or CIA. Then this was all about the algorithm. Now coming to the HIV and the syphilis, without which the topic is incomplete. That is, as we all know, in HIV there is unusual serological response has been observed among HIV infected person who have syphilis. It is due to the high serological titers. That what do we expect is serological titers higher than expected, false negative serological test results, and delayed appearance of the seroreactivity. Both treponemal and non-treponemal serological tests should be interpreted in the usual manner of a majority of the patients who are co-infected with Treponema pallidum and HIV. Now, in the cerebrospinal fluid examination in the syphilis, what all we can send? Where all we can send it for the cerebrospinal? What are the indications? When the patient has the symptoms of the meningitis, when the patient has optic neuritis, hearing loss, cranial nerve abnormalities, and if the patient is HIV positive with late or latent syphilis positive, and all the infants suspected of the prenatal syphilis. In all these conditions, CSF for the syphilis is sent. Syphilis testing is sent. Now, in the lab parameters of the CSF, what we can see is CSF pleocytosis, that is more than 5 cells are seen, and the CSF protein is more than 40 milligram per cell. And CSF VDRL, though it has high specificity but poor sensitivity, then CSF FTFBS has high sensitivity when compared to the VDRL. And then if it is all positive, send one serum sample for the VDRL, which is reactive in about 2/3 of the neurosyphilis cases. Now, this is the CSF profile in different neurological stages. That is the early stages where the person is asymptomatic. They have, but in this asymptomatic also, we can see that CSF leukocyte will be more than 5, proteins will be more than 45, that is CSF protein. And at that time, if we send at RPR, it is most likely positive. Then we have in early we have meningitis and ocular. Then in early late we have meningovascular, where the symptoms will be dizziness, personality changes, stroke-like symptoms. It will occur 1 to 7 years from the onset, and the CSF leukocyte will be reaching from 5 to 100. Basically, in neurosyphilis, the leukocyte count should be more than 5. So here it will be reaching around 100 to 10 to 100, and protein will be reaching up to 200. In the late neurosyphilis, the stages are general paralysis and tape dorsalis. In here the clinical picture, here the lab parameters are almost similar, but the clinical signs and symptoms and the duration of the onset is pretty late. That is after the 20 to 25 years these symptoms start. Then next, now this is the paper which says that clinical spectrum of the neurosyphilis among HIV negative. We have talked about the HIV positive patient, HIV positive patient and neurosyphilis, syphilis positive. But here, this paper talks about the neurosyphilis among the HIV negative patient, that is in the modern era. So here they have concluded saying that the positive rate of the CSF RPR and CSF TPPA were 57 and 89% respectively, whereas the CSF pleocytosis and elevated proteins were around found in 40% patients. So at the conclusion here it says that the neurosyphilis has various clinical manifestations, lab findings, and MRI and electroencephalography findings. But all these studies, what I have mentioned, lack the specificity. So at the concluding statement here, they have every patient with neurological or psychiatric symptoms that are without unambiguous causes should have test for the syphilis. When serology proves positive, patient should undergo the CSF examination. No. Treatment then comes after talking about the neurosyphilis. Let's go regarding the treatment and management of the pregnant women for the syphilis. Now the whole the algorithm for this pregnant women is based regarding where exactly is the pregnant woman present. If she is present in an area where a laboratory is present, or if she is present in an area where laboratory is not present. Now, this is the subcenter or the cases specifically coming directly in a labor at any point of care, and where there is no functional laboratory, go for the rapid POC. If there is a functional laboratory or attached to a medical college or tertiary setup, then perform RPR or VDRL. Now, this is the main crux of this algorithm of the pregnant woman, that is whether the laboratory is present or laboratory is absent. Going to the antenatal screening, that is at the first visit of the pregnant woman in the obstetrics department. The first here, this is the first workflow is when the patient visits to the services which has no laboratory. So the pregnant woman, the first is screening pregnant women for the syphilis using point of care test, and then because there is no laboratory, use only point of care test. If they are reactive, refer to the nearby PHC or CHC or district hospital. There they will do the RPR or VDRL. Then if it is non-reactive, then wait, call her to up till the third trimester or the labor. Again, if they are found syphilis, follow the same order. Now if they are RPR or VDRL, if they are reactive, you can treat the patient, and as well as the sorry not treat, assess the patient mother and the fetus. Now this is workflow is in regard to the health setup where there is no with the laboratory setup, laboratory support, that is in the medical colleges. The first ANC registration, ask the patient to get done the RPR or VDRL. If it is found to be reactive, then immediately treat a patient with benzathine penicillin and then go for the confirmatory test, that is the TPHM. And if it is non-reactive, then assess the patient till the third trimester and up till the labor. In this case, in this time, if they are found to be positive, then again follow this same protocol. Then after that, then after treating and after the confirmation, repeat the VDRL at the time of the delivery and assess the infant for appropriate treatment. And after the delivery, again after the 6 months, call for the repeat sample to assess it. Now screening. Now what will now how you do screening when the patient directly comes during the labor? That was the antenatal. So in the labor, when even if there is a laboratory or no laboratory, it doesn't affect. So directly when the patient comes in labor, directly go for the point of care test. If it is non-reactive, then retest as a high risk individual, and if it is reactive, first treat with the patient the pregnant woman and the partner with benzathine penicillin and the newborn with 10 days curative treatment, and then later on test it for the RPR or VDRL. Now, how do you follow up such cases? The treatment efficacy assessed by the clinical evaluation and monitoring fourfold decline in VDRL or RPR, that is from 1:32 to 1:8. Now, if this happens, that means that the treatment, there is a treatment efficacy. Now, if it doesn't happen, then which I said in the previous slide is a seroresistance. Then primary and secondary syphilis cases should be examined at 6 to 12 months after the treatment. Okay. Then the latent and the late syphilis cases, these cases should be examined at 6, 12 and the 24 months. And the frequent serological testing recommended for the patient with HIV syphilis co-infection, that is 3, 6, 9, 12, 24. And the neurosyphilis disease activity correlates best with the CSF pleocytosis, CSF repeated after every 6 months till the count fall to the normal. This is the important point here to be noted. The treponemal test remains positive despite adequate treatment, so not useful for the following up of the treatment. This line we have actually covered in the treponemal testing slides only. Now coming to the, after all discussing all this, now coming to the treatment part, the primary, secondary and the early and latent syphilis can be, if there is no penicillin allergy, treat with the benzathine penicillin, that is 2.4 million international unit, that is intramuscular single dose. and if the patient is penicillin allergy, tetracycline 500 milligram or doxycycline. In the late or the later tertiary syphilis, in the same, the benzathine penicillin, and if it is penicillin allergy, tetracycline or doxycycline. But when it comes to the neurosyphilis, here we use different formulation of the penicillin, that is aqueous penicillin or porcine penicillin, that is 18 to 24 million unit, that is IV, quarterly, if you are using the porcine penicillin, that is 2.4 million international units for 10 to 14 days. Why there is a use of aqueous penicillin in neurosyphilis and primary latent is due to this benzathine penicillin does not penetrate or does not cross the blood-brain barrier, whereas this aqueous penicillin can cross the blood-brain barrier. This is one of the reasons we use the aqueous penicillin. So the conclusion of all the conclusion slide would be the diagnosis. As we all know, STI is one of the resurgent STI, and the diagnosis is very challenging and require construction of the serological profile. And also know that there is no gold standard treatment, gold standard uh, diagnosis for this. The only thing we can do is the serology. So syphilis immunoassay remain important and commonly requested test both in this low risk and such as pregnant women and in the patients at the higher risk with or without clinical suspicion. The traditional testing which is long held practice. It is important for the laboratory to be prepared to explain the interpretation of the test if moving to an reverse algorithm. Then treponemal testing cannot distinguish between treated and untreated infections. Patients with discordant results should be considered for the therapy. The traditional approach to the serodiagnosis of the syphilis has been the use of non-treponemal screening assay followed by the treponemal screening test if the initial non-treponemal screening test was reactive. The clinicians and microbiologists should be well informed and well educated on both the benefits and the interpretative challenges of both the testing algorithms. Thank you.
Your one question is pending from Dr. Rathore. What tests are done to evaluate congenital syphilis?
So what is that? So in the congenital syphilis, we first in the congenital syphilis we can use the serology from the patient. That is the IgM serology of the fetus, which is done, and to diagnose the congenital syphilis, mother's serum is generally preferred over the child, which is the newborn. And for congenital syphilis, the amniotic PCR can be done, and amniosis we can do dark field microscopy to diagnose congenital syphilis. And
I think you check this up. Read it up and write a note.
Okay.
Okay.
Sure, ma'am. I will come back with the unanswered questions.
Yeah. Please do come back. I don't see any more questions now. ठीक है बेटा, इनका रिप्लाई जो क्वेश्चंस रह गए हैं ना, उनका रिप्लाई बना के सबको सर्कुलेट कर देना. If you need any help,
Thank you.